So welcome everyone. Welcome to our 28th in the series of Tuesday evening webinars. I am delighted to have with us tonight Professor Claire Hopkins, who is president of the British Rhinological Society. So welcome, Claire, and I'm so glad that you can join us this evening.
Hi there, good to be with you.
Before we begin, I've got a couple of housekeeping notes. If you have a question for Professor Hopkins, please put that into the question and answer bar rather than in the chat. That would be very helpful. That helps us keep track of the questions. If you have questions about COVID-19 or parosmia or anything else on a different subject, do please wait until the next webinar when we will be talking about different topics. But for tonight, it will be CRS and polyps. So Claire, I know you are a very busy lady, and I would really like to thank you for taking time out of your very busy schedule to talk to us tonight. You and I have had the chance to come together and work together during the pandemic. I know that CRS is your main research interest, but of course, over the past year, you have really changed the face of COVID-19 and smell loss. Everyone in the AbScent group knows who you are, and I'd like to also quickly thank you on behalf of everyone for the work that you've done for us. So that's very important. And it's lovely to have you with us. Tonight, we're talking about EPOS for patients, and I think a great place to start would be with the title. Tell us what EPOS is all about, and tell us about this paper that's specifically for patients.
So EPOS stands for European Position Paper on Sinusitis, and it's a working group that started to write guidelines around 2005. We were a group of sinus surgeons in clinical practice, but also interested in research. And it became very apparent, even going back as far as 2005, that there was a huge amount of research being published. And it was very difficult for doctors to stay up to date with the latest developments. And as a result, it meant that there was a big variation in practice. And what we all know as a postcode lottery, your treatment would depend very much on the centre that you were going to. Some centres were very up to date and offering, very modern treatments. Some centres were lagging a little bit behind. And it was very difficult to make sense of the huge amount of medical research that was being published. And so we set about to try and summarise evidence and set out what we thought was the best practice based on the latest evidence at that point in time. Now, EPOS 2020 was published last year, and it's the 4th edition of that main guideline designed really for ENT surgeons. And it's gone from being a guideline which was about 50 pages long to now being 400 pages long. It's a huge document. It's very complex. But within that, we include a number of what we call systematic reviews or meta-analyses, where we take all of the evidence on one topic. We look at the quality of that evidence. We combine all of the outcomes. So we can make recommendations to doctors about, how good are steroids in the treatment of nasal polyps, or how effective is surgery in the treatment of nasal polyps, and so on. And within that, we've created a number of guidelines to really help ENT surgeons make sure that they offer the best care and to help patients get a very high standard of care no matter where they go. Now, having written it, and one of the things to be really clear, for the first time this time around, we got patients involved in actually developing the recommendations that we made, because we realized that there is no point recommending a treatment if the side effects of the treatment, for example, or the way in which the treatment has to be given isn't acceptable from the point of view of a patient. So patients were already involved in developing the EPOS 2020 guidelines that went out to doctors. And it also highlighted areas that were very important from patients' point of view in terms of, what outcomes really matter to patients, for example. How should we measure success? And of course, it has to be measured from the patient perspective. So there's been a lot of patient input in the main document. But one of the things I learned, I think particularly through my involvement with groups like AbScent from COVID and anosmia work, was how important understanding the condition, understanding why doctors make different recommendations, even just knowing the terminologies to patients. And I think if patients better understand what treatment they're being given, why they're being given it, they can better make decisions. And hopefully we've all moved to a place of what we call shared decision making. You know, the days when you would come to hospital and a doctor would tell you what treatment you were going to have hopefully long gone. And instead, you know, a doctor should be explaining to patients the different options that are available, the risks and benefits of all of those choices, and allowing the patient to make their own decision based on that information and their preferences. And that's very difficult for patients to do because, you know, we're all very bad at using medical jargon. We're taught from medical school to use complex Latin names for everyone, for everything that we do. And I think partly it was to create this air of mystery and keep the patient away from really understanding what was going on. And we're trying to move away from that. So patients need information in lay terms that they can easily understand. And there's often not time in a consultation to find that out. So EPOS for Patients basically is putting all the medical information from the main book, hopefully into a more easy to read, easy to understand form that we can give out to patients so that they can learn as much as they want to about the condition that they would like.
I think it's so important for anyone who has got a troubling condition like this one that can be really difficult to live with. For the patient to learn as much as they possibly can about what's going on. Somehow that demystifies, you know, the way you feel. And I'm absolutely agree with you 100% that one of the best things that anyone can do for themselves when they have a smell disorder, or in fact any health condition, is to really you know, familiarize yourself with what's going on so that you can, you know, better understand and perhaps better understand your own management. So I think that's a very important point.
You know, we've seen just from the COVID Facebook groups, you know, how much patients are able to learn and understand their condition. I think, you know, doctors often underestimate their patients.
Agreed.
And patients, you know, really like being familiar with hyposmia and nosmia. And I see discussions with patients talking about the receptors involved in COVID and all kinds of things with a level of understanding far greater than some doctors. And clearly, a lot of patients want to have that information available. The problem is at the moment that you go to the internet and you never really know what you can trust. And not all information on the internet is correct. And so what we wanted to do was create, based on best evidence and you know, the opinion of a very large group of doctors who are leading in their field, a guide for patients that was hopefully reliable, that includes frequently asked questions, that includes a glossary on the terminology, that includes links for other sources of information that we know will give good, reliable information. So to really package all of those questions that you wanted to ask in the consultation and you forgot or you didn't have time to, into one area so that patients can come back to it afterwards.
I mean, in a way, and I've been through the document, it's the Bible of, you know, everything that you would like the patients to know. It's just an amazing document that goes into such great detail. How are you planning to bring this to the patient community? What do you see as the most effective way of bringing all these messages in a way that's understandable to the individual patients?
So one of the thoughts is that any of the ENT surgeons who are members of the European Rhinological Society, so most surgeons, for example, in the UK who perform sinus surgery, deal with chronic rhinosinusitis, will be members, will be able to download the guide, give their patients links, print off individual sections in the clinic. The document is freely accessible to any patient on the internet, so we need to do some work to make sure it appears high in Google searches, for example, so we can really disseminate it. In the UK, we're working with a patient group on the back of this, which will hopefully set up as a group for patients who suffer with chronic rhinosinusitis. There isn't a specific group for patients like that at the moment, and they will help disseminate. And then we're going to use things like this webinar to raise awareness and other things that patients can access on YouTube, just to really find out how they can get good, reliable information and get themselves to EPOS for Patients.
Of course, so much information as is contained in that document all at once can be a bit overwhelming. So it would be a great thing to kind of cut it down into bite-sized pieces I know we're finding that out in the work that AbScent does with people who've had post-viral smell loss. So I think that's a really a good way of getting information across is through short videos, as you know, because you and I have made some for the Nosewell pages that AbScent has. That they're really useful, and as long as they can be kept bite-sized, they don't feel so overwhelmed.
Well, the other thing is each section within EPOS for patients, for example, the one on oral steroids, is written so it can be read on its own. So you can just go to the one bit that's relevant for you. So you don't have to, start at page 1 and work your way through the whole document.
Right, right. Wonderful. Okay, so let's start with some of these new guidelines for polyps and biologics also. Would you like to describe that a little bit and what patients might expect to be coming in the future?
We've learned a huge amount in the last 10 to 15 years about why patients develop polyps and the underlying physiological mechanisms within the body that cause polyps to grow. And we're now very clear that it's inflammation and not infection in the nose. And therefore, it leads us to question how we can optimize treatment for that. And in the past, we've relied very heavily on steroids, either given in the nose as nose drops, which can be very effective, or given orally. And oral steroids are fantastic treatments for nasal polyps. However, the benefits are very short-lived unless you continue on them long term. And there are many side effects from anxiety, difficulty sleeping, weight gain, and immunosuppression. And in particular, relevant for women, thinning of the bones. So we're growing in our understanding that you can't repeatedly give patients oral steroids. And the evidence suggests that having more than 2 courses a year for your nasal polyps starts to push you into being at higher risk of side effects in the longer term. And so we're having to look for alternatives. We've also learned a lot about how to make sure surgery is more effective and the benefits for surgery last for longer. And putting it in its simplest form, we know that actually the more surgery you do, the more polyps you clear, the longer it takes for them to come back. But also the wider you make the openings into the sinuses, the better you can deliver nasal steroids. And so we can then use the nose to get steroids in directly without taking tablets in steroid form and all the risks of side effects that come with that.
Right.
Following on from that, there are a whole load of new technologies that look to get steroids into the nose better. So in the US, not yet available in the UK, is a mouth-activated steroid delivery device. You sort of blow the steroid up into the nose, and that gets in at higher doses and more effectively. There are other, what we call steroid-eluting stents, little sort of almost mesh-like dressings that you put in the nose, leave them in place, but they deliver steroids over 6 months. So again, you get better delivery of steroids. And so that will allow us to make sure the benefits of surgery last for longer, and we're less likely to need to take patients back into theatre or rely on oral steroids to get them better.
Could you just explain again? I'm not familiar with that technique of putting sort of something into the nose that lasts for 6 months. What exactly does that look like? Does that have to be done under anesthetic, or is that just done in an office setting?
Well, at the moment, there are what we call these little mesh-like stents that you can put in at the end of a surgical procedure. So as you finish the operation, you just put this tiny little mesh in. It dissolves by itself over a period of 4 to up to 6 months with some of the most modern forms. And it contains little particles of steroid embedded in the mesh that slowly get released into the surrounding tissue directly in the nose. So instead of relying on patients having to remember to use nasal sprays or drops, and I know with my own hay fever spray, I forget to use it as often as I remember. It just constantly delivers steroid into the nose without having to actively deliver it in the nose. So you get a much better constant level of steroid in the nose.
And when you say it's a stent, does that mean it's a little tube?
It's a little tube, yeah, that's
So
almost like a mesh that expands. So you can't see or feel it. It just sits up in the openings that have been created at the time of surgery until it dissolves. Now, the technology is really moving apace, and there are now similar forms that can be put in the nose in outpatients without surgery that will do the same thing, that again will hopefully reduce the need to have an operation. So it's one area that's really changing things in the last over the last few years, and is likely to come into the UK and Europe
And
in the next few years.
so it's not available yet in the UK.
So I've just started using the stents that you can put in the nose at the end of surgery, but we haven't got the ones available in the UK yet that you can put in outpatients.
Very interesting. Good. Well, thank you for describing that. Now, tell us a little bit about what's going on with biologics, especially here in the UK.
So moving on from steroids, we've tried to find better ways to suppress the inflammation that causes polyps. Steroids are like napalm for the immune system. They wipe out everything, the good and the bad, and that's part of the problem. So one of the things we've learned is which specific parts of the immune system we need to target to block polyp formation, but allowing the rest to function normally. And there are little cells in the immune system called eosinophils, which are really the sort of the targets for polyps and have very little useful function in the rest of the immune reaction. They were designed in evolution to fight parasitic worm infections. And fortunately, in the Western world, that's a very rare occurrence for us. So biologics are drugs which are basically a form of antibodies that directly block the action of eosinophils and other related inflammation specific to nasal polyps. So it's a very, very targeted form of attack, unlike our prednisolone or napalm for the immune system. And the benefit for that is that you can continue to give it long term without all the very wide-ranging side effects of nasal steroids. And they are tremendously effective. In some of the patients I've given biologics to, I've given them a treatment on the Friday. By Monday, I get an email to say that it's like a miracle. Their sense of smell has come back to normal. They can breathe. It transforms patients' quality of life in often very short periods of time. So they're amazing treatments.
And how are these treatments delivered?
So at the moment, they all have to be given by injection into the skin of either the thigh or the belly. So patients will come up to have the first couple of injections, very much like a little diabetic syringe insulin injection in the clinic. And then we teach them how to give them the injections themselves. And they're given either 2, 4, or 8 weekly, depending on the drug and how well patients respond. And so they will continue to use the treatment long-term to maintain the benefit. It's not a treatment that you can take for a short period of time and then stop without the polyps coming back. So it will be a long-term treatment. But they are in about, well, depending on the drug, anything between 50 to 80% of patients will notice really dramatic improvements. And for those with Sampras triad or those that also have asthma, it will also help control their asthma symptoms and their reaction to non-steroidals. So if you've got 2 conditions, it will treat both of them together, which is fantastic because the disease mechanism is very similar.
And what are the side effects of biologics? Are there any that are, worth considering if people have other kinds of health conditions and so on, or is it pretty well tolerated?
They are largely very well tolerated. Certainly in the trials, the placebo arm, the group that had a blank injection, actually reported more side effects than the patients in the active arms for the trials that we've done so far. In real life registry data, we've seen that patients in a small number of cases develop some side effects such as joint pain and very rarely have to stop the drug because of that. Some patients get a dry eye, very few patients get hair loss. So it's certainly not without any risk of side effects, but compared to the risk of side effects from oral steroids used long term or from surgery, the side effects are relatively less.
Right. Okay, so that sounds very promising. Sounds like a wonder drug, but at the moment it's not available to everyone.
No.
And why would that be?
So because of the way these drugs were developed and also the way that they have to be manufactured, their antibodies are not simple chemical formulas. They are hugely expensive. As a rough guide, 1 injection costs anything between £800 to £1,000 for 1 treatment, and it obviously has to be given long term. Now, they are approved for use in both the US and Europe. However, they are not reimbursed everywhere. That is, the cost of the drug isn't covered by the state healthcare system. And certainly in the NHS, they're not yet approved for use in patients with nasal polyps. In the UK at the moment, there are a very small group of patients that qualify for treatment with a biologic, and that's those patients with very difficult to treat asthma. And that would be patients that have 4 courses of oral steroids in a year because of their asthma, or 4 admissions to an A&E for an infection, or a combination of the two. Now,
Right.
nasal polyps, we don't have a similar acute exacerbation index, but we have applied to have these drugs recognised by NICE. But because of the cost of them at the moment, NICE have not yet approved for the drugs to be used in the NHS. And so we're working on, at the moment, trying to define a group of patients with nasal polyps who will derive the most benefit from these drugs, and in whom we think that the costs of the drugs are justified and that they should be made available. And we're going through that process at the moment.
For people who are listening who don't know, can you tell us a little bit about what NICE is? NICE is the acronym. So what does that stand for, first of all, and how do they review a drug here in the UK?
Slightly embarrassingly, I'm not sure I know what NICE stands for. I think it's the National Institute of Clinical Excellence.
I think that's
we've got many other things that we might pretend it stands for, because they're not always very nice. But essentially, they make all decisions about what treatments can be offered within the NHS based on evaluating the evidence for how effective a treatment is, but also they use a metric to work out how much it costs. And
right.
unfortunately, in the NHS, a lot of things come down to the bottom line and come down to cost. And they use quite a complex algorithm to work out how much it costs for one added quality adjusted life year. And they basically compare the cost of the drug to how much improvement you get in a series of metrics. And then they work out this cost per quali. And to get a new drug approved, it has to come under a threshold of 20,000 per quali, and so on. Now, the problem is that, as anybody that has nasal polyps will know, the main problems are loss of smell, nasal obstruction, difficulty sleeping. It has a huge impact on people's quality of life, but it doesn't stop them climbing the stairs, getting themselves dressed, or going out to work. And many patients with polyps will struggle on through and carry on with their normal daily life as best as possible, even though they can feel really unwell. The problem with that is that the metric that NICE uses basically works out whether somebody is incapacitated by their disease. So it measures if you can climb the stairs, get yourself dressed, and get yourself to work. And unless your disease has a big impact on those, it's quite difficult to show benefit. Unfortunately, NICE don't really care about somebody's sense of smell. And I was really disappointed in one of the first meetings that I went to, when I tried to describe what having nasal polyps was like, was that somebody on the panel said, well, so what? It just sounds like a bit of a cold. And, anybody that has this disease will know how, damning that statement can be. And so what we've realized is that we actually need to get patients with the condition in front of the people that make the decision to help us convince them what an impact it has. So that's some of the work we've been doing, trying to capture patient experiences so we can measure it in a better way to present, and get a group of patients that will come together and help us put the case forward to NICE. But at the moment, based on the way that NICE work things out, the drugs are too expensive for the improvement in the metrics that they measure. So we've got to try and find a way to convince them to think outside of their normal box and put a value on sense of smell and quality of life.
It sounds to me that while NICE does say use criteria like, can you get dressed, can you get to work, can you walk up a set of stairs, they haven't really considered patient quality of life, or they haven't perhaps queried the patients on what it's like to live with their condition. Is that the way NICE works, that they don't necessarily listen to patients, but rather have these kind of tick box approach to working out the value of a drug in a person's quality of life? It seems to me slightly odd if they want to make a judgment about someone's quality of life without asking people directly.
They use a measure called the EQ5D, which is supposed to be a quality of life measure. The problem is that the aspects of quality of life it measures aren't particularly relevant to patients with chronic rhinosinusitis, and that's where we fall down. NICE have a very difficult job. There is a very limited pot of money. They have to make decisions between the latest chemotherapy for cancers to hip replacements to treatment for depression and dementia, they have to compare an ever increasing number of drugs with ever increasing price tags across many conditions. And so it is very difficult. So they have to find one metric that they apply to all diseases.
Right.
The problem is that just doesn't work very well for patients with chronic rhinosinusitis. So we've got to find a way, at least with the biologics that we have, because obviously we can't make the drugs cheaper. That's not something that we can decide to do. And that price is set by the drug companies. But we've got to find a way to convince NICE that for at least perhaps a relatively small number of patients, there really isn't a good alternative, and these drugs must be made available.
Right, right. And do you think there's any chance that in the future the price of these drugs will come down?
Well, with any new drugs, there are obviously development costs which have to be paid back. One of the problems is actually manufacturing these drugs are quite expensive. So I think there'll be a limit to how much it can come down, but there will be increasing competition in the market. There will be a number of new biologics available. There will in time be what we call biosimilars. So similar drugs based on the original development, and that will drive the cost down. So that will inevitably make it easier to get these drugs approved.
Right, right. And obviously this sounds like a fantastic treatment, but do you ever, treat the actual polyp itself? Is there any way you can inject the polyp, or is that just not something that's done?
So polyps are often multiple, so that there have been a number of trials trying to inject things into polyps individually, but it just doesn't seem enough. But that's where these idea of these steroid-eluting stents to put treatments directly into the sinus cavities become very attractive. And there are certainly trials looking at, can you develop biologics that you can put in these kind of drug-eluting stents? Can you put other compounds in? So there is a lot of research going on in parallel to the development of biologics to look at better ways to develop drugs into the heart of the sinuses where the inflammation takes place, not just steroids, but other compounds as well, that would actually be more effective, more likely than injecting the polyps that are there, because they'll also stop new polyps forming.
Right. Good. Okay, I'd like to just pause right now and say to everyone who is in the audience, if you have a question for Professor Hopkins about chronic rhinosinusitis or polyps, do please put that into the Q&A bar. Right, well, thank you very much. Now, Claire, maybe we could talk a little bit about the macro study, which I know you are instrumental in, if not the originator of. Is that correct?
Yeah, that's correct. So myself and Carl Philpott, who is a surgeon in Norfolk and Norwich, developed the macro program together. And certainly what we know in the UK is that, well, across the world, traditionally surgeons have never been very good at evaluating the outcome of their own surgery, particularly, as I've mentioned, from the point of view of the patient. And so we've always judged the success of an operation based on how the nose looks, for example, and what the CT scan looks, but perhaps not always asking the patient. And we've never really therefore questioned whether the surgery that we offer works or not, and how well it works and in whom it works best in. And so one of the points of macro is to really get a better understanding of how effective surgery is for treating chronic rhinosinusitis in the longer term, whether there are different types of surgery that might be better, whether there are certain patient groups that do much better with surgery and other groups that perhaps don't do so well. At the same time, we can say the same for some of the medical treatments that we give. And there is an antibiotic called clarithromycin, which if used at low dose over longer term can have very useful anti-inflammatory effects. But we don't fully understand which group of patients are better suited to clarithromycin, for example, compared to surgery. And so macro is a whole program of research really aimed to try and improve the management of patients with chronic rhinosinusitis, with a very large multi-center trial right at its heart. And so within the trial, which is taking place at 15 centers across the UK, we're recruiting patients with chronic rhinosinusitis and asking them to consider being randomized to treatment. And what that means is that instead of offering them a treatment of either macrolide therapy or surgery, and the evidence that we have available at the moment really suggests that there's very little to choose from between the two in terms of relative risks and likely benefits, but asking them to allow almost at random a computer to make the decision as to which treatment that they're given. And we then compare the outcome of all the patients in the trial in the hope that at the end of the trial, we'll have a much better understanding as to which treatment to offer to which type of patient with chronic rhinosinusitis. Because within the bag of chronic rhinosinusitis, it's a bit like a sort of mixed bag of sweets. There are lots of different types of sinus disease, and we think that some treatments likely are better suited to different subtypes.
When you say there are lots of different types of disease, I mean, I know that there's CRS with polyps and CRS without polyps, but is it much more a much more varied picture than that? You know, how do the variants differ?
So with and without polyps are the two main subtypes, but we also now think more about the sort of the biological signature of different types of chronic rhinosinusitis. So within that, we've got three main inflammatory signatures, for example, type 1, type 2, and type 17. And we're learning much more that actually it is a very mixed bag of conditions. And by trying to put all patients in one group and treat them all the same, is probably doing many a disservice. And that's why we really want to try and better understand all those different subtypes, how to identify them, and what treatment will be the best for each group.
And when you say there are 15 centers all over the UK and they're enrolling patients for this, how long does this study last? How long will you follow each individual patient?
So each patient will be involved in the trial directly for 6 months. They will be, from their first visit, randomized to receive either medical or surgical treatment, and that should be started within 6 weeks of that first appointment. They're then followed up at 3 months and at 6 months. In clinic, and then what we're doing is annual follow-ups via questionnaire through email every year after that for 5 years. So we want to understand at 6 months, which we think is a good important marker, which treatment comes out best at that point, but also we want to understand what happens further down the line, because we know with chronic sinus disease, polyps, for example, can come back. You might get repeated infections, you might need to go back and have a second operation, and we really want to understand the long-term benefits as well as that early 6-month outcome.
Fascinating. Okay, great. Let me ask you now about the SNOT-22 test, which first of all, I love the name of that. I think that's a really inspired title for that. How did that come about and what is it used for?
So similar to the theme we've been talking about, we started to understand in the late 90s that where we're operating to improve someone's quality of life, the most important outcome is that improvement. And therefore measuring CT scans or measuring grade of polyp, has very little importance to the patient. And the most important thing is, how does their disease make them feel and how well do we change that? And in order to understand how well treatments work, we need a metric that allows us to measure over time how that quality of life changes. And it's very difficult to remember how you felt 6 months ago and really think about whether you've changed or not. So we need to use measures that can be repeated every time a patient comes to a hospital visit, for example, to see how things change. And so we use questionnaires that ask patients to rate the severity of their symptoms, and it can be repeated over time. And the SNOT-22 is basically what we call a patient-rated outcome measure. It includes 22 different symptoms, which are all relevant to patients with chronic rhinosinusitis. And it's been developed based on interviews with patients to make sure those symptoms are what's important from the patient perspective. And they rate each of those items on a scale of 0 being no problem at all to 5 being worst imaginable problem. So it gives them a total score, anything between 0 and 110. And the idea is that if they repeat that on every visit, you can very quickly see if they're getting better, worse, or staying the same. And then when you recruit patients into studies, if they all complete those outcomes, it allows you to work out how much change they get from different treatments and compare the effectiveness of different treatments. So they're really helpful from that perspective. And I was very fortunate at the beginning of my training, I was asked to get involved in developing these patient-rated outcome measures. And they've become a really important part of how we practice medicine now. So they're now used routinely in the clinic. All of my patients fill in a questionnaire every time they come to the hospital. They're used in trials. and the SNOT-22 has been completed up at the top of Everest in an expedition. So, you know, it's now used all around the world and really well recognized, which is great.
So I assume that that must mean it's also been validated in itself. You know, if it's been used that much, something that, you know, that everybody understands is something that works. And
yes, I mean, when you develop these tools, there are certain tests that you have to perform, statistical analyses, psychometric tests, to make sure that they are valid, that they do what they're supposed to do, and they're reliable. And when I did my training, I did a PhD developing the SNOT-22 and used it in a study of about 3,500 patients back in 2000 that's still considered the gold standard for research in this area in sinus disease. So people often go back and compare to that. But it's now been used in hundreds of studies all around the world. It's been used for other conditions as well as chronic sinus disease. And so all of that information we put together, and we're still learning how to refine it and how best to use it.
interesting. And has it been translated into other languages?
Yep, I think about 50 at the moment. So I quite often get sent copies of different translations. And I'm very fortunate because I was involved in its development, and sort of I get invited all around the world to teach other people how well to use it as well. So it's been great. Obviously not very much at the moment.
Right. Fascinating. I mean, I'm as you're talking, I'm thinking to myself, this might be a very useful tool for post-viral olfactory loss, to develop some kind of you know, way of measuring that, because people often ask, you know, when am I going to get my sense of smell back? When actually I think that a better question is, you know, when does your quality of life return? And the two things are not necessarily the same.
That's true.
And so I do think that's a really valuable lesson, and something I'll keep in mind. Good. Okay. So I mean, looking forward, you've mentioned before we went on air that you're hoping to start up a new patient group for people who've got sinus disease. Maybe you could tell us a little bit about that.
I think one of the silver linings that's come from COVID and my work with anosmia is actually working with the team at AbScent and realizing the importance of really listening to the patient voice. And I've learned a huge amount from reading the Facebook pages, from taking part in webinars. And it's really focused the areas that we need to research. And I think that's really valuable. And I would love to be able to incorporate that into my chronic rhinosinusitis research. And at the moment, there isn't really a group that allows patients to promote their voice and for their voices to be heard in chronic sinus disease. And I think that's a real shame, particularly, you know, we've talked about getting NICE to appreciate the impact of biologics. And I think having the strength of a patient group is really important. So Andrew Nill, who is one of the authors of EPOS, who is a patient with chronic sinus disease, but also works within the healthcare system in terms of promoting research and working with pharma companies. So he has some experience from that side of things, is starting up something called Sinus UK, which is a patient charity group for patients with chronic rhinosinusitis, really to try and replicate many of the fantastic things that AbScent have done, act as a source of information, act as a way to gather patient views so that they can be used for research, to signpost patients to trials, to basically advise trialists to make sure that their trials are looking at the right treatments and measuring the right things.
I'd be very happy to lend you a hand and do whatever I can to assist you in that. I mean, we do have on the AbScent Network, we have a section for polyps and sinus disease. So we do talk about that subject there. I know we've had several interesting threads recently in the original AbScent group talking about polyps. So, you know, it would be easy enough for me to facilitate, you know, bringing more of these people together, or some of these people together with you and with Andrew Neal. So I'm more than happy to help you with that.
Thank you. That would be
especially, I mean, thinking about the EPOS for Patients document, if I had a Bible like that for COVID-19 smell loss, you know, it would be an amazing tool to just break down into little chunks and push out there for people to you know, dip into, depending on whatever it is that they're interested in on that day. So you are starting with a really amazing asset in this paper. So I think you'll have you've got something very good to work with already.
The challenge that, you know, research generally takes a long time. And so the trials in biologics take generally 5 years from starting to recruit to writing the paper. What's incredible about COVID-19 is the research has been compressed into, you know, some of our papers we've written and got published within weeks, which is absolutely unheard of. You know, I've published, I think, nearly 100 papers in a year. And that's hugely challenging when you want to try and put that information together. You know, EPOS will probably have to be revised in 5 years' time because it will be out of date. The challenge if we write a handbook for COVID-19 is it will be out of date in 5 weeks.
Right.
And that's very difficult for us as researchers to keep up to date with, let alone share that information in a way that's accessible for patients. So, you know, that's a very difficult area. And I think you're doing a fantastic job in getting information out to patients as quickly as we hear about it.
You started out by talking about the fact that the whole EPOS body of work started because no one could keep up with all of the research that was going on. And certainly when I think about, you know, the small number of papers that were available on COVID-19 back in sort of March, April last year, I mean, really, it was just you know, might fill a page. And now, I mean, there are literally thousands of articles. Yeah. Nobody can keep up. I review a list of recent articles that is sent to me by Professor Hummel every couple of weeks. And I just look through them and I lose the will to live because, you know, no one could read everything and stay up to date, let alone digest it. Of course, I'm not, I don't have a medical background, so it always takes me a lot longer to read a paper. But you know, occasionally if we do get one that we think is exciting, then we'll try and break it down and put up something either on the network or on the website so that everyone has access to it. But that is a real problem.
Yeah.
So much information, boiling it down so that we get, you know, not just sound bites, but that we transmit information in a way that is worthwhile for people's time and again, improves their quality of life. It gives them a better understanding of what's going on and makes them feel better about you know, living with their condition. I think that's really important, but a big ask.
Yes. Ask. There is a, similar to EPOS, there's going to be a document specifically for loss of smell. The ICARS anosmia document will be coming out later this year. Zara Patel, who is a leading researcher and good friend from Stanford University, is the lead editor. And again, it's very much a document that tries to summarize the best available evidence. And we started work on it before COVID. But because its main focus is loss of sense of smell, obviously the document has had to change to adjust to include COVID. So there will be a very large number of sections focusing on COVID anosmia. And I was tasked to write the section on the underlying mechanism and what we understand about it. And of course, I've had to update my own section half a dozen times, even before it's sort of gone to the publishers. But that will be coming out later in the year. And I think, you know, hopefully that will make a good attempt to summarize and evaluate a large amount of the literature, obviously up to the date it's published.
Do you think there's any chance that there will be an ICARS for patients?
Well, I hope so. And I will very much propose that on the basis of how successful the sort of uptake of EPOS has been and how well received it's been.
Yeah, of course, that would be wonderful. Good. Okay. So I don't know whether or not we've got any questions, but Claire, I know that you could talk all night and you're a fountain of information. So is there anything else that you think we should cover tonight that would be of interest to patients who have sinus disease?
No, I think, you know, just to reassure patients, there is a huge amount of research going on in sinus disease. I think treatments will really escalate and improve over the next 5 years. And I think for the vast majority of patients, we will find a way to get really good disease control. And I think that's something that's eluded many patients up until this point in my career, but I think we're at a real turning point. And I think the days of patients needing to have multiple surgeries and still suffering with polyps, for example, are coming to an end, fortunately.
That's excellent. I'm just going to check if we've got any questions. I think we've got one, but that might not be. Sarah's going to get back to us on that. And Claire, what's happening next for you? I mean, I know that you are constantly, you're a perpetual motion machine. What's coming up for you in the sort of next couple of months?
So we're opening a new trial for a new biologic. Certainly there'll be no resting on our laurels, and we're always looking at ways to improve the outcomes to find a biologic that will treat a larger number of patients. As I said, we've got about 80% response rate with the ones we've got at the moment, but we really want to push that up to being as close to 100% as possible. Macro will continue, and we have lost a year to 14 months of recruitment because of COVID, so we've got to do a lot of work to get macro back on track. And then hopefully in the summer I will try to find time to take a holiday. It's been a very, very busy 18 months, and I'm looking forward to turning off the emails for a week at some point.
I think a holiday is in order for everyone that's been
Yes.
working on this. We do have one question, Claire, and that is, when operating on sinuses or polyps, are there any risks to the delicate apparatus of the nose? And by that, I think the sense of smell is intended. So if you are removing polyps, what are the risks to the sense of smell?
So polyps usually grow from the sinuses and physically obstruct the olfactory cleft, the delicate area where the smell nerves sit. So fortunately, they don't often arise from the olfactory cleft themselves. So we can normally operate very carefully to remove the polyps without directly instrumenting or removing any of the mucosal lining from that very delicate area. So hopefully we can minimize the risks of scarring. But that is always at the back of our mind. And we do see some patients who, after many surgeries, seem to lose their ability to get their sense of smell back after surgery. Now, some of that we think is just long-standing inflammation causing some internal scarring within the lining, but also we worry that sometimes that is the impact on some of our surgery. So, again, we're learning a lot more by studying outcomes in patients, the importance of really meticulous surgical technique, great care in that delicate area, really targeting where we're operating. And again, using other techniques to minimize the risk of having to go back in to do repeated surgery. There are other risks with surgery that are extremely rare because we're operating very close to the eye and close to the brain, but the risks of damage to those are astonishingly rare, fortunately. And we now have very clever instruments. For example, we have basic what I call sat-nav for the sinuses, what we call image guidance, that allows us to operate in these very delicate areas, knowing exactly where we are, mapping out the anatomy, and allowing us to take polyps out very safely.
Amazing. Good. All right. Well, I think that answers the question. But let me ask you another, something else with polyps and smell loss. I mean, obviously there is a mechanical blockage that's keeping the air from getting where it needs to go for smelling to take place. But is it possible that, over time, the olfactory bulb, we know, will lose volume if it's not receiving messages? And do you think that having the polyps sort of, makes the olfactory bulb lose its ability to smell as acutely as it would in a healthy person?
I'm less worried about that because we see patients who have had no sense of smell for 5, 10, sometimes 20 years regain their sense of smell on biologics. And literally, they say it is like a miracle, because they've gone from nothing to regaining a normal sense of smell. So I think, although there is a worry that there may be irreversible scarring within the lining because of long-standing loss, I think the chances are for most people that smell nerves are still functioning, the olfactory bulb is still healthy, and that we can regain it with the right anti-inflammatory treatment.
Good. Well, I'm very glad to hear that. I think we can wrap up. Claire, do you have anything else to say? Any final messages? Anything that you think we might have missed?
No, it's a great pleasure working with you and everyone at AbScent. I do take on hopefully comments from patients, and that really helps direct our research. So I'm very grateful for all the time that patients have spent answering any questions from me, and surveys and other things as well. So thank you.
You're quite welcome. So we look forward to hearing more about what's going to happen for patients with CRS and polyps in the future. And you will be hearing about that obviously in the AbScent network, in the AbScent Facebook groups, and on the website. So Claire, thank you again very much for having been with us tonight. And I'm sure that we will see you in the future in another webinar. But that's all from us tonight. So see you in a couple of weeks. Good night, everyone.
Thanks, Chrissy. Bye-bye.
Bye.